that we are going to start recording on WebEx, and the recording will be available on the Mental Health SF website. Ms. Dodka, please start the recording. I wanted to go ahead and welcome everyone to the November 2022 meeting of the Mental Health San Francisco Implementation Working Group. Wanted to also acknowledge that this is American Indian Heritage Month, and if you get a chance to please visit the American Indian Cultural District's website and their work. They're doing tremendous programming this November season and a lot of beautiful things. So we want to make sure that we are continuing to support our grassroots Indigenous movement. So thank you all so much. Please note that we are going to call the meeting to order. Ms. Dodka, could you please call to order? Just remember that also if you are connecting by your phone, that you need to also connect to WebEx audio when you join the meeting. If you're not sure how to do so, please use the chat to connect to the IT host who will help you do so. Ms. Dodka, sending this to you.
Thank you, Chair Lassar. So yeah, just wanting to share, as we do each meeting, that this meeting is being held by WebEx pursuant to the governor's executive orders and mayoral emergency proclamations that continue to suspend and modify requirements for in-person meetings. We are continuing to convene remotely, and public comment is available on each item on this agenda, and folks will have 3 minutes to speak. I'm going to call roll call now to establish quorum. And if you can just say here present. Member Eisen? Member Eisen? Absent. Member Fields?
Present.
Member Gonzalez?
Here.
Member Hammer?
Present.
Chair Lassar?
Present.
Member Lipton?
Here.
Member McWiggin?
Present.
Vice Chair Patterson? Didn't see him yet. Member Salinas?
Present.
Did Member Short join us yet? Until they do, Member Wong?
Hi, good morning, present.
Awesome. So we do have 8 out of the 11 members present, so we do have quorum to continue. And then
Great, thank you.
Then I think I'm also going to go through this to vote on excused absent members. I don't believe we received, correct me if I'm wrong, Jen, but I don't believe we received any emails from folks excusing them. Yeah. So right now we do have, looks like member Eisen, but I think she joined us just now, and I think we are waiting on member Short, and then we didn't get an email from Vice Chair Patterson. So I think most likely it will be that we would be voting to excuse member Patterson, since I think member Short will be joining us once they log on. Can I don't know, Chair Lassar, if you wanted to share anything, or if we should go for that vote.
I think we could vote now. However, why don't we, if it's just Vice Chair Patterson, why don't we move that to later? And then if he doesn't join, then we can vote then.
Sounds
Is that
good.
cool? Okay, thank you. So should we move on to meeting goals?
Yes, back to you.
Okay, great. So today we have, let's see, I'm just trying to get to them on my screen. Several meeting goals. We want to be updated on overarching mental health SF updates and understand evolution of the offices or the Office of Coordinated Care's Bridge and Engagement Services team, the BEST team. So we have a crew coming on from the BEST team, which we're excited about. And we want to provide input for the upcoming December implementation report. We are wanting also to remind folks, please take bio breaks as you need to. Just remember to turn your camera off and turn it back on when you come back. And also, we do note that we have turned off the chat function for all panelists and the public due to issues of accessibility. For added comments, questions, or concerns, please email mental health SF email. Next slide. A reminder of what we are here to accomplish. The charge of this work group is to advise on the design, outcomes, and effectiveness of mental health SF to ensure its successful implementation of the ordinance domains. Today we have speakers whom we have heard from before and some new ones who are directly engaged in designing and implementing mental health SF domains. This includes our fearless leader, Dr. Hillary Cunnins, Mental Health SF Director, and a team from the OCC's Bridge and Engagement Services. We have Director Weisbrod, Office of Coordinated Care Director. We have Wojtek Kawalak, the BEST Manager. We have Koi Dang, Senior Behavior Health Senior Behavioral Health Clinician Team Lead. We have Doug Foster from Behavioral Health Clinicians, representing Behavioral Health Clinicians, and Sylvia Chavez, a peer counselor. So a really beautiful group of folks. At this point, Ash, do I turn this back to you?
Actually, I'll take this one if you
Done. Okay, thank you.
Sure thing. Yeah. As we say for each of these meetings, because we're having a remote meeting, is as authorized by the California Code Section 54953E and the Mayor's 45th supplement to her February 25, 2020 emergency proclamation. This meeting will be held remotely without providing a physical location. The state requires that we submit what is referred to as findings every month. These findings are that the IWG as a public body has reviewed the teleconferencing meeting status in relation to the COVID state of emergency. The formal requirements titled Resolution Making Findings for Teleconference Meetings are posted to the IWG website, and by state requirement, we must review and record our findings every 30 days. We know this is going to be changing for the coming year, but this is the position that we are in for the remainder of 2022. So Ash, if you could advance to the next slide. So these are the two resolutions that we will be voting on. We are resolving that the state of California and city remain in a state of emergency due to the COVID-19 pandemic. At this meeting, the IWG has considered the circumstances of the state of emergency. And secondly, is as described above, because of the COVID-19 pandemic, conducting meetings of this body and its discussion groups in person would present imminent risks to the safety of attendees. The state of emergency continues to directly impact the ability of members to safely meet in person. So IWG members, are there any questions about these findings as they currently stand, or any other questions before we move to a vote? Hearing none, Chair Lassar, are you ready to open the floor for public comment?
Yes, please.
Awesome. So members of the public who wish to provide public comment on this item would call the number for this meeting, which is 415-655-0001, and access code for today, which is 2485-747-7444. And then you press pound and then pound again, and then you'll dial *3 to line up to speak. I'm going to see if we have any callers. No callers. I'm going to close public comment, and now we can move to a vote from IWG members. And we are understanding and submitting to the state the finding that will not meet in person for the next 30 days. Do I have a motion to approve this resolution?
So moved.
So moved.
So
I'll
that was,
second
I think that was member Ison and then member Fields. Awesome. I will now call roll call and ask each member to vote yes or no to approve the remote findings. Member Ison,
Yes.
member Fields,
Yes.
member Gonzalez,
Yes.
member Hammer,
Yes.
Chair Lasar,
Yes.
member Lipton,
Yes.
member McGuigan,
Yes.
and member Salinas,
Yes.
member Short,
Yes.
and member Wong.
Yes.
Great, we have 10 yeses, 0 no's, so we do have a majority vote to approve these remote findings. We are now going to do the last round of approvals. These are for the meeting minutes.
Great. Thank you. So for the approvals for the meeting minutes, we again need to poll, I believe. So these are posted on the IWG website. Are there any changes to the minutes as posted on the IWG website? Please let us know. Anyone? I'm not seeing any hands yet. Ashlyn, do we go to public comment then again now?
That's right. So
Thank you.
another round of public comment. You'll call 415-655-0001, access code, which is 2485-747-7444, then press pound and then pound again, and then dial *3 to line up to speak. There are currently no callers in the queue, but I will wait a little while longer. Since there are no callers, I'm going to close public comment and we'll do that roll call vote again. Do I have a vote to approve the October 2022 meeting minutes?
So moved.
Great. Member Fields
Seconded.
and Chair Lasar. I will now call roll call. Member Ison,
Yes.
member Fields,
Yes.
member Gonzalez,
Yes.
member Hammer,
Yes.
Chair Lasar,
Aye.
member Lipton,
Yes.
member McGuigan,
Yes.
member Salinas,
Yes.
member Short,
Yeah.
and member Wong. Awesome. We have 10 yeses, 0 no's, majority vote to approve the October meeting minutes. And now we are going to hand it over to Chair Lasar, who will introduce the director.
Thank you, Ms. Stadka, and thank you, everyone. Love the enthusiasm and the variability of the yeses and the ayes. Thank you. We are now turning our wonderful time over to Dr. Hillary Cunnins. We are very excited to have you with us. As always, please take the floor.
Hi, good morning, everyone. I also appreciate the enthusiasm. Thank you for having me and being willing to listen to me. So it's great to see everyone. So today, just for table setting, just marks an informal update. I know this is in sort of rapid succession after our last meeting. So today, I just wanted to focus on a bunch of contextual things that are happening in the behavioral health sector that have been over the last couple of weeks. So it isn't necessarily specific to the MHSF programming. The other thing I just wanted to start with, we got a couple of questions on provider directories last time when we were presenting at on sort of the mapping of our services, and we really appreciated all the feedback and direction, and we are eager to meet the needs that you all identified. We did send out, and maybe Chair Lassar, if you can just confirm the link to our provider directory, which does exist, needs likely to be more user-friendly, which we want to acknowledge, but also want to acknowledge that it does exist. And I hope that that got sent out to members. If it didn't, it will come. So turning now to sort of the myriad things that have been going on in the last couple of weeks. We have been participating in several public hearings, and I wanted to update this group on what we are discussing and what's happening, as I think this really is important context for all of the work that you and we are doing here. So first, I wanted to share with the group that there was a hearing held on November 9th at the Board of Supervisors about Baker Place's PRC. I think, as this group likely knows, there has been financial stability issues at Baker PRC that have led to, among other things, a request by the agency to transfer particular programs. We have been working as DPH very, very closely with Baker PRC to make a plan that prioritizes the continuity of care for existing clients, most importantly, as well as aiming to preserve the behavioral health care and human services continuum in San Francisco. So we are in the process, in order to achieve those two goals, as well as supporting Baker PRC to achieve more financial stability and sustainability, have identified some programs for transfer, and the first two of these is in motion. The first, importantly, is the Joe Healy program, which I think probably everyone knows is a withdrawal management or detox program. That service was actually transferred to HealthRight 360 as of yesterday. Current clients in Joe Healy will complete their course of care, but new clients will be admitted to HealthRight 360. The basis for that is that HealthRight 360 responded to an RFP for this service now several years ago, and was scored and was considered eligible for those services. And the next program that is intended to be transferred also to HR 360 is Acceptance Place, also a substance use program that will be effective in early January. We are continuing our work together, and know that there may be some additional programs that will need transfer. We are speaking with providers, including some of the folks in this group. So I know I'm conscious just of potential conflicts, which someone will advise us on in our conversation, to, again, achieve stability for current clients as well as for the sector as a whole. The next Board of Supervisors hearing that I wanted to share information about with this group is a hearing on the Tenderloin Center and Wellness Hubs, which was held now about 2 weeks ago, November 3rd. I think, as this group knows, and as we've spoken about, Department of Emergency Management was responsible for organizing and coordinating the Tenderloin Emergency Initiative, which was declared almost a year ago. As part of that initiative, Department of Emergency Management launched the Tenderloin Center on January 18th, 2022, with us, and also important partnership from the Department of Housing, Homelessness and Supportive Housing, HSH, and DPW. DPH assumed management responsibility for the site on July 1st, 2022. We see and saw the TLC as one strategy as part of a multi-pronged plan to work to support the Tenderloin, to decrease and reduce overdose deaths, as well as increasing connections to health and human services. The Tenderloin Center, I think, as all of you likely know, is serving approximately 400 visitors or guests a day, 7 days a week. And between January 18th and the end of October, we, the center helped place over 1,000 people in shelter and over 200 in permanent supportive housing. The center helped people complete enrollments, more than 600 people into CalFresh, Medi-Cal, and CAP. Multiple showers, over 8,000, and loads of laundry, over 3,000 were provided, as well as tens of thousands of on-site behavioral health, physical health, social service, and housing support activities. Approximately a little more than 300 people were connected with formal behavioral health services, and we reversed more than 280 overdoses. We also found that despite these successes, the site experienced some challenges, largely due to the location and size, and we are anticipating that the site will be closing in December. We are expecting and will be working very closely with guests and area providers to make sure that we can facilitate connection with the services that are nearby in the Tenderloin. TLC staff, Tenderloin Center staff, will be in the area and around the site full-time for at least a week after closure to continue to help navigate clients to existing programs. We, as you know, also announced under our overdose prevention plan that we are hoping to open 1 to 2 wellness hubs in the next year. I do want to just share with this group that we are still navigating both real estate and legal challenges to open sites. These are intended to be neighborhood-based programs tailored to meet and improve the health of people who use drugs, and really focusing on preventing overdose deaths. Okay. You can see we've been very busy with hearings, and there is one more that I just want to mention, and some of you, thanks, were there and also provided testimony, and that is the treatment on demand hearing. I think as many of you have been involved with, the 2008 Treatment on Demand Act, also known as Prop T, requires that the San Francisco Department of Public Health provide adequate substance use disorder treatment capacity to meet community demand. Supervisor Raphael Mandelman called the treatment on demand hearing on October 27th, and we reported some of the key facts were that total funding for SUD services growing a bit from 71 to 75 million from fiscal year 21 to 22. We are also have been working to strengthen the continuum of substance use disorder services as part of our overdose prevention plan, and has been happening under Prop C funding as well. This includes psychosocial treatment, medication treatment, additional assessment, linkage and service navigation, transitional housing supports, and prevention services. That's quite a mouthful, and you may have additional questions. We learned through data analysis of our network patients, that is the San Francisco Health Network patients, that includes primary care, hospital-based care, and of course, behavioral health care. We found that in 2021, about 36% of network patients who had a substance use disorder diagnosis received a substance use disorder service somewhere in the network. That compares to less than 10% nationally. And one of the central challenges for the field, for all of us, is really shifting our approach to not only serving the people raising their hand for treatment, but really taking an engagement approach to pull more people into treatment. And the fact that we, as a network, as a DPH network, could found that 36% were in treatment is very good, although we know much more work is needed. We did see a decrease in admissions to our formal specialty care behavioral health system, but we saw at the same time an increase in buprenorphine use. Buprenorphine, as you all know, is one of the effective medications for the treatment of opioid use disorder. Unlike methadone, it can be prescribed in other than opioid treatment programs like primary care, like mental health care, like street-based care. And so the fact that we saw buprenorphine treatment or use increasing suggests that as we create more avenues for treatment, people are taking us up on it. For our own services, we were able to, for the first time, do some standardization of our wait times for services. What we learned from this past year's analysis, or actually this past year's analysis, which is not in our report yet, but will be in our report of February 1st, is that most clients are entering substance use disorder residential treatment through withdrawal management programs. And the wait time is essentially eliminated because the entrance to residential care can be arranged from withdrawal management or detox. 81% of our patients, clients, are entering residential treatment through that route. For clients who do not enter that route, our median wait time for getting into residential care has decreased to approximately 4 days, a median wait time. That is a decrease from between 5 and 6 from the prior year. Now, both for the prior year and this year have been confounded, as you know, by COVID, by some COVID restrictions, by some staffing issues, which I know we have addressed and will continue to talk about, that are a result of workforce shortages, but also there have been periods where a variety of programs have been short-staffed due to outages because of COVID. So we obviously are all hopeful that that will continue to decline and that we may even see further decreases in that wait time. Finally, there is a less than 1 day wait time for entry into opioid treatment programs or methadone maintenance. The next report will be released in February 2023, and so we are working already on revising the report and being responsive to some of the important feedback we got, both from the supervisors and the various folks who provided testimony, including the Treatment on Demand Coalition. Okay. Lastly, I always have more than I think I do. Lastly, I wanted to mention care courts and our work that is beginning to be underway around preparing for care court implementation. I think as most or all of you likely know, the care court legislation, the care court stands for Community Assistance, Recovery, and Empowerment. Legislation was signed into law by Governor Newsom in September and will go into effect in a phased approach starting next October, 11 months from now. That will be a small cohort of first adopters, including us, along with about 6 other counties. We will be receiving some one-time funding to support both planning and implementation for the program, and we are working closely with, intending to work closely with the courts, the state, the mayor's office, other key stakeholders in the planning process. Just in case, and we're all trying to, figure this out right now. This is a new program, but just for folks' additional background, the program is intended to serve people who are, and I quote from the legislation, unlikely to survive safely in the community without supervision, people whose condition is substantially deteriorating, and people who are in need of services and supports in order to prevent a relapse or deterioration that would likely result in grave disability or serious harm to the individual or other people. Participation in the Care Court program would be indicated only when a care plan or care agreement would be the least restrictive alternative necessary to ensure a person's recovery and stability. The plan would include mental health treatment, stabilization medicines, wellness and recovery supports, and connections to social services and housing. The program also includes and requires person-centered approaches to the care that include collaborative care planning, development of psychiatric advance directives, and inclusion of a supporter to advocate on behalf of the participant. So as I mentioned, it is a new program. You and I still have a lot of questions about it. And we will keep this group posted as things move forward. It is still very, very early in the planning. I will stop there, and I believe that I have some time for questions, though my apologies, this went on a bit longer than intended.
No, thank you so much. Firstly, yes, to confirm, it was sent out 2 weeks ago. And yes, there is a link on the IWG site as well to the provider directory. So thank you so much for that. I'm looking for hands in the chat to see. Of course, Member Fields, please.
Of course. No. Yeah.
Of course. Well, I mean, first off, Member Fields, I have to say this. I've been doing my homework on you, and you have some of the most phenomenal history of this work. So I just want to really big up you and your work, and I can't wait to dig into some of the materials that the written materials, and hopefully hear more. So just that's why I'm saying, of course, you have a lot to say, and I appreciate it. So thank you for all of your work. Just want to say that as well, all the history of your work. Thank you.
Thank you, Chair Lassar. That's nice of you to say. Thank you, Director Cunnins. It's great to hear the report and the update. There's a lot happening. I have a question about the Care Court process. Again, because we're coming out of COVID, we've been in COVID, and I know it's early, but clearly community providers are going to be critical to making this work, and particularly the CBOs that are in that arena. And you know better than anyone with your impressive history working with substance use treatment, the relationship between involuntary treatment and successful treatment is a fraught one in terms of whether or not there's evidence that if you make somebody go to treatment, they're going to really benefit from it or participate. And of course, the Care Court major problem really is what's the consequence to an individual who doesn't follow through on their plan. And I think that still isn't even articulated well in the legislation. What do you see now as the process for CBHS to bring in early the perspective and participation of the various programs that will be instrumental in implementing this into that early discussion?
I would say at this point, Member Fields, it's on our extremely lengthy to-do list of involving community-based providers, and anyway. So it's on our list. I knew you were going to ask that question, and it's very important to me and to us. I also think you're raising, I think, really two critical issues that I think you hit the nail on the head. One is the interplay of substance use and mental health here, and trying to, my intention and our intention is to create a care plan and treatment plans that really meaningfully include addressing both those issues. So that's first, is really an opportunity to think about this in a very integrated way and what folks need. Not that everyone will have substance use alongside their mental illness. And I should just say that the qualifying condition, which I did not review, is having a psychotic spectrum disorder. So that is the qualifying condition. Very importantly, I think one thing in the legislation is if the psychotic spectrum disorder is as a result of their chronic or intermittent substance use, they are likely that alone is likely not to be eligible, but I think that is still getting worked through. So that's one thing, and I hope I'm not misspeaking. There may be others who understand this better than I do, including you, Member Fields. The other issue which you raise, which is the role of both the role and effectiveness of involuntary treatment, number one, and then the consequence for not adhering to the treatment in the care court. The consequence, I fully agree, is not spelled out in the legislation, just for everyone's awareness. And I think also, as you know, the role of involuntary treatment, the effectiveness of involuntary treatment, and maybe this is worth a whole separate talk, is mixed. And I think our stance in behavioral health is, you know, as many of you point out, is a recovery-oriented, engagement-oriented, person-centered approach. And many of the times, and many of us who have been in the work for years and years know that sometimes what is a person's, quote, refusal of service is really as a service provider, fumbling and not so nimble attempts at sort of selling treatment or selling interventions to people because, and we can all do better. So I think we're very much holding that dear, that principle and approach dear, as we think about this in planning. And I look forward to more because it's really,
Yeah.
it's a big deal and we'll need much input.
Thank you.
I just wanted to add, I'm really pleased that last point you made, because I don't think that that importance of talking to the person about bringing them into an understanding is a critical part of that line between involuntary and voluntary. We don't do it enough. Person says no the first time, and the clinician or the person who may be in an emergency room, or even a case manager isn't in a position to work with the person to bring them toward an understanding of what it is they're resisting. So that's going to be critical, because our experience in the field, I think a lot, is that when it's truly client-centered, part of the engagement process includes trying to overcome the hurdles someone may have to be engaged in treatment. And too often, because we're so overwhelmed, we don't do that enough. And it seems like it's the client's fault or the individual's fault, rather than our ability to truly engage the resistance and try to deal with it. So I'm looking forward to this. Thank you. I appreciate your report.
Agreed. Thank you so much, Member Fields. I have a member, Eisen, Salinas, and Short. And then after that, I know we need to move on. Member Eisen.
Thank you. Thanks, Dr. Cunnins. Given the imminent and impending closure of TLC, without a replacement in that community, like I look at data coming out of there and I see an overdose was reversed yesterday, and there was like 6 on one day last week, I think. So what is the city's plan for addressing the issue of potential overdoses in that community with the closure of the site in the Tenderloin?
Thanks.
Yeah,
Thanks for
I
the
feel like,
question.
they're like people, right? They're like, they've always been people, but having done the work, having the city having done the work to stop doing the work, it just feels so kind of unbearable. So sorry to put so much on it, but I'm hoping that there's a plan to address overdoses in the immediate that immediate community.
So thanks for the question. And we I'll just acknowledge again the sort of the heaviness that Member Eisen just conveyed. You know, I think what we've been able to accomplish at the TLC is really show that people can and will come into care and attention when you create a space in which folks are respected and are taken for who they are and where they're at in their lives. And I think that for all of us, and really apropos, frankly, of the comments that Member Fields just raised, is creating services that speak to a person's needs rather than is a way to pull people into care and engagement. And so I think we saw that people show up for the care, and just to acknowledge Member Eisen was very much part of that, as well as a number of other people in this group. And so I think you and we should feel proud of that. I think we are really aiming to strengthen through current pathways and new ones, helping to keep people safe from overdose and drug-related consequences in the area. And we will do everything we can through either current approaches, strengthening approaches to try to keep the overdose prevention, important overdose prevention work going. I do want to acknowledge that there continue to be legal challenges at every level of government that has challenged some of the city's ability and context for moving this forward in a more straightforward way. So I do want to also acknowledge that, but just appreciate the question very much.
Thanks.
Agreed. That was, thank you, Member Eisen. That was my question as well. And thank you for your team's work, for all your work as well. It's been incredible to witness from afar. Member Salinas and Member Short.
Hi, Dr. Kuhns. Good morning. I wanted to ask a clarifying question about the wait times for residential treatment. Just to clarify, were you speaking specifically about the SUD residential treatment programs?
Very specifically, yes, very narrowly.
Okay, and I'm wondering if at some point in the future we can get an update on the wait times on the dual diagnosis residential treatment bed wait times.
Yes.
At some point in the future.
Yes.
Okay.
That is our intent. Absolutely.
Thank you.
It's long, as you know, longer. And we just a word on data just for a second. And I just because I think, Member Salinas, your question, we've referenced this a couple of different times over the course of this group meeting. I very much value using data to improve systems and performance. And we have been slow to be able to produce that data broadly. Our data systems live in disconnected places that require a lot of routinizing workflows, matching and cleaning data. And one group of people that has been hard in our workforce challenges to recruit and retain have been analytic staff. So we have been moving forward. I know we're aiming to present some of our key performance indicators in an upcoming meeting. So our team is working very closely to be able to share that with the group. And at the same time, we know that some services that wait times anecdotally are long, including dual diagnosis. So I want to appreciate the question, and this is not for those services particularly. I'll also add that we are really aiming for all programs to have levels of competency to address both substance use disorder and mental health conditions, and that as a field, as a sector, if you are coming from one side of that fence, SUD, or the other side of the fence, mental health, thinking about your own programs and how we can all strengthen our service delivery capacity to really handle co-occurring disorders, since they are so very prevalent. So that's my sort of wish back to all of you and us as we move the sector and sectors forward. That was a longer answer to your very narrow question.
I appreciate, I think that for our clients, our more complicated clients in the ICMs, it has been very helpful that we can go over to TAP and get someone in by the next day, you know, into a SUD residential treatment program. Joe Healy was also very instrumental always, but our clients tend to do much better in the dual diagnosis programs. I think until recently, they hadn't been accepted for the most part into SUD programs. So I appreciate that the SUD programs are trying to meet the needs of a more complicated dual diagnosis clients, but they don't fare as well in those programs. Particularly folks with very complicated medication regimens and such. I think in the dual diagnosis programs, they fare much better. I think the client to staff ratio is much smaller, and they're smaller programs. And so they do much better in those dual diagnosis programs. But for the short term, we're continuing to try and get them into the SUD programs and see how far they'll make it, you know, in the program. But at least the facility of getting them into those programs has been very helpful.
Well, I'm glad for the positive
Thank you.
feedback and also the sort of nuanced feedback about ways in which we can strengthen the larger sort of sector of programming while we're still intending to procure more dual diagnosis services.
Yeah, and it's great to hear about the pathway. So we look forward to hearing more data, and good luck on hiring for the analytics and for getting your analytic work moving. It's really important, and I know it's really something you've been pushing on, Dr. Cunnins. I'm getting the high five sign, but I'm gonna, well, it's actually the hook, you know, from the Apollo. But I'm saying the high five sign, meaning I'm gonna get Member Short's question in, and then we're gonna go to public comment. So Member Short.
First, I just want to point out there's a lot of technology employees who have recently looking for jobs. So maybe, you know, but I was at the TL Center hearing, and the ask, you know, from the community was, can we ensure there's a replacement of the services that are being provided there before it closes? And you know, I heard your responses, just as you said earlier, location and legal challenges and, you know, things like that. And the supervisor, Preston, I believe at one point asked, sort of tried to get at the heart of that, like, what is the real barrier here? Is it money? Is it location? And I just want to make sure I understand, because I think that you said that funding is not the issue, that you do have a budget or some funding, you know, attached to this, that the larger issue was finding the location. And I know a little bit about that and that why that's been so hard. And so I just want to clarify that, because in part, because I'm also wondering the response to kind of, well, what happens, you know, on, I think it's December 3rd, or where, you know, when it actually shuts down to these people who've been using the services. And it was described by your department, what you said, you know, you're going to be there to encourage them to go to other services and, you know, and I have to be honest, I thought what other services? You know, that's part of why we have this TL center, is because there wasn't enough around, you know, specifically in the TL. Yet there are definitely some wonderful programs and services, but they're all, you know, under resourced, understaffed, and, you know, and all of that. And so putting that all together, I guess that makes me wonder, is there an intention or plan to further support some of the organizations, you know, in the TL that are doing this work, to help them expand and meet the need that will be coming when this happens? I guess that it's a question, and it's also a recommendation. You know, like if you're hoping to, you know, walk people over to, you know, a different service, that they've got to be able to handle that. And I'm afraid that they really are not as we stand. And especially if we're talking 400 people a day. So curious about that. Thanks.
Yeah, thanks for the recommendation. We are we are beginning to speak with other providers in the area, or have begun. I think I know that some of those conversations have begun, and I think your recommendation is well taken. And I will bring that back and see where we have some latitude. I want to again acknowledge, point to some of the legal challenges again. I just want to add that to your member short, noting real, you know, issues around space as well. So focusing on those two issues, I think, are really important.
And can you just confirm that there is some amount of funding if you were to continue, the services?
We believe that that funding for this fiscal year, we know that funding for this fiscal year is possible. So though there is not sort of a line item budget, but we believe we can make it work for this year. Should and when we find space and open.
Thank you.
Thank you all so much. Great conversation. I don't see any other hands, which is great news because it is now time to go to public comment. Thank you so much, Dr. Cunnins. Oh, please, go ahead.
And sorry, just before, it's great to see everyone. I'm going to be on and off the meeting as I have some other things I need to attend to. So I know I often chime in during the course. So I'll jump back and I'll raise my hand if I'm here, but I'm apologizing in advance for not being here the whole time.
Thank you so much. We appreciate you so much. Thank you. Ms. Dodka, can you take us to public comment, please?
I sure can. So members of the public who wish to provide public comment should call this number 415-655-0001, and the access code for today, 2485-747-7444. Then you'd press pound and then pound again, and then dial *3 to line up to speak. I know that there is somebody, there was somebody earlier who had called in. I see 2 raised hands right now, so I'm going to unmute the first caller I saw in the queue earlier, and then we'll do the second. All right, first caller, you've been unmuted.
Can you hear me okay?
Yes.
Thank you. Thank you, Dr. Kunin, for your hard work. As a family member, I would like to point to 2 things. One is that dual diagnosis is really lacking because also the people who go for rehab, for drug rehab, they have much more rigorous plan, many meetings which people who have mental illness cannot follow, so they get kicked out of programs. So we definitely need something like another Joe Ruffin, because when my son tried to get to Joe Ruffin, it was full. There was no place for him. he was in 7B in General Hospital, got medications and stopped taking meth while he was at 7B. But the next thing they did, they sent him to harm reduction program, which of course he started taking meth again, and he ended up in PES again. So the connection between one thing to another is lacking. A person who is dual diagnosis should not be in harm reduction, especially in my son's case. So the connections between programs is lacking. To me, it's such a waste of time to be in 7B for 2 weeks and then being sent to a harm reduction place where he's just, as a revolving door, he's back into the hospital. So these are two things I wanted to mention. Thank you so much for hearing me.
Thank you so much for sharing. And I think we're going to now go on to the next caller. Second caller, you've been unmuted.
Hi. I just want to say that since the inception of this working group, we've been asking for mapping. We've been told, oh, nobody knows where anything is. Suddenly, we have a list. Now that established programs are being closed instead of expanded, because now there's all these new, like, competing street, intervention programs and stuff where things that were working are getting lost. And I just think that that is shameful. I think it is absolutely shameful, because anybody who works in mental health knows that continuity of care and having dependable places that people know they can go to is like the keystone of mental health. And I'm just, I got to tell you, I am so disappointed. It's really clear that the minute all this money was available, people, before the group even was able to convene, people had their own agendas, they got their own contracts. I'm just speechless. I'm sorry. I know you guys have been working really hard, but how can you be effective when these unknown entities are making decisions ahead of the information that you're even able to access? It's crazy. Thank you.
Thank you so much to both callers and for joining us in this meeting today. That is it for public callers. Before I move on to the next item, I just wanted to open space for Chair Lassar. I know we can't respond directly to them, but if you want to say anything.
No, just thank you so much. We're so happy to hear your voices and get your feedback. Please continue to stay with us in this process. We need you. We're a team. We can't do anything. We really have no say unless community tells us, or we should have no say unless community tells us what you want and need. So please continue to call in and connect with us. We hear you loud and clear. Thank you. Yeah, so I guess on that note, we are now moving into discussion item number 4, Office of Coordinated Care, BEST team. And let's see. We also want to welcome to the floor Max Rocha and Heather Westbroad. I think that's old, y'all. So I'm going to skip that. I think that's an old note and just move on to say, let's focus on design, outcomes, and effectiveness of the mental health SF. And so we are bringing on, again, the folks that I mentioned before, Wojtek Kowalek, hopefully I said that correct, Koi Dang, Doug Foster, and Sylvia Chavez. Welcome.
Thank you, Chair Lassar. I'm going to start off giving an overview of OCC, just a reminder and refresher about the Bridge and Engagement Services team, and then hand it over to the team who are going to describe what they do and what their day-to-day life is like as a member of the BEST team. Unfortunately, Wojtek had an urgent client issue out in the field, so he's not able to join, but really this is, the spotlight is on the team providing the services. So, I'm really, really excited. As I know that we have been talking very theoretically about OCC and the Bridge Engagement Services team, so we're really excited that you are all going to be able to meet some of the team members providing this great work. If I could get the next slide. So I'm going to do a kind of brief refresher about BEST, and then I will turn it over to the BEST team members, Koi Dang, Deb Foster, and Sylvia Chavez, who are going to talk through, they're going to introduce themselves, talk a little bit about their background, and then talk through kind of what a typical day is at BEST, some client stories, some themes that have arisen from work, lessons learned, and then we'll leave some time for discussion. If I could get the next slide. And then the next one. So as a reminder, these are slides that I presented when I was last here in September. I'm very happy to be back with this update. The Bridge Engagement Services team is part of the Office of Coordinated Care's Care Management Transition Support Services section, which is focused on providing centralized care coordination and case management, really focused on helping people make transitions between levels of care. And really right now, I think we are starting out our focus at, with people who are making transitions between or out of more acute levels of care, or who have complex needs that impact engagement in behavioral health services. I could get the next slide. The Bridge Engagement Services team provides bridge case management. So they're really focused on working with people who have pretty high acuity needs, who are leaving, as mentioned, leaving acute settings, who are leaving jail, who have historically poor connection to behavioral health services, and who have just had trouble engaging into our system and need some extra support to do so. So they provide field-based services, a sort of outreach and engagement. So they are really, and you'll hear some of this today, really focused on trying to work with clients over a period of time to determine what they need and to engage based on the needs that individuals are bringing. They provide connection to both health and non-health services. So they are connecting people to our behavioral health continuum. They're connecting people to physical health care. They're connecting people to housing, to benefits, to basic needs, to legal services, whatever the person needs in order to stabilize. And then there's some minimal bridge behavioral health services as well, while in the process of connecting people to behavioral health in order to make sure that they are well supported. And this is related to we just wanted to kind of make the link between the IWG recommendations and this work, and one particular recommendation, which is that no person should be discharged from care without a safe landing and appropriate care coordination, including but not limited to housing, which we feel is really what BEST is focused on, is really helping people make those transitions, holding them, and make sure that they get connected to the variety of services that they need. And if I could get the next slide. So this also I presented in some form last time, but we do have a couple of updates. So BEST was launched in January 2022, and I'm very happy that Koi Dang, who's our very, very first OCC staff person, is here with us today. He really helped stand this whole thing up, so I'm excited for you to be able to meet him. We have 8 of 15 BEST staff hired, and we have BEST is it's an ECM provider, so a CalAIM enhanced care management provider. So it provides both ECM services, non-ECM services, that we've been taking referrals from health plans, Medi-Cal managed health plans for ECM services. BEST is taking referrals from hospitals, and we are working right now on implementing the next phases, which are working with the criminal justice system and jail health to make sure that we're able to support people who are leaving custody and needing connection to behavioral health services. One of the major accomplishments since I last was here in September is that we launched Epic. So I know I had talked a little bit last time about our new electronic or health record system that will help integrate us into the larger DPH system, and that provides a lot more functionality in terms of data and communication. And so we went live on that last week. So that is a really exciting accomplishment and really supporting, I think, the work that BEST does. And let's see, I think, and then we're also working on our systematic 5150 follow-up project. So taking referrals now for people who have been placed on 5150s, but working on continuing to systematize that follow-up to make sure that we are kind of tracking and following everybody who needs connection. And if I could get the next slide. Okay, so I will not take too much longer. We'll introduce the team. I just have to say, one of the things that I really have been so impressed about by this team is that everybody is coming from many different places around the system. I feel like we have, when people go around and introduce themselves and talk about their experience in the team at large, they represent experience in every single corner, it feels like sometimes, of the system, which is really, really beneficial to the work that we're doing and all of the connections that need to be made in terms of people's care coordination and services. An incredibly dedicated team and really, have launched into this the startup really wholeheartedly. So I'm very excited to bring some of them here. So we are going to hear from Koi Dang, who is a senior behavioral health clinician and one of the team leads for the Bridge and Engagement Services team. And then we're going to hear from Doug Foster, who's a behavioral health clinician who is part of Koi's team. And then we'll hear from Sylvia Chavez, who's a peer counselor working with clients across BEST. I think we can maybe stay on this slide. And I will ask, check Koi is here. Yes. I will pass it over to Koi to introduce himself.
Thank you. Good morning. Thank you for having me here. My name is Koi Dang. I'm a senior behavioral health clinician. I'm one of two clinical supervisors for the BEST team, Bridge Engagement Services team. My role is to provide clinical supervision, support, guidance, and also role play different scenario during supervision. I supervise behavioral health clinician, health worker, and peer counselor. Also carrying a caseload of high needs and complex clients. I think one of the thing that I really enjoy is also doing supervision to encourage, educational advancements and also career advancements, which lead me to my background. I actually started, I've been with the city and county for over 20 years, starting out as clerk typist and having the opportunity to get my master in ethnic study. I was kind of pushed and encouraged by other clinicians to go into social work. So I went back and got my master in social work. I started my social work career in Child Protective Services with San Francisco Department, Human Service Agency, Family and Children Services. At which time I was collecting my hour for my LCSW. I had the opportunity to move to Department of Public Health with the transition program, doing placements and assessment and care coordination as a behavioral health clinician. And I had the opportunity to join OCC as a senior behavioral health clinician, which, is challenging in a sense, and also for me, learning new skills, which I'm really enjoying, and starting from the ground up with a new program. I'll end it there, and I'll pass it on to Judd to do the introduction.
Hi, everyone. My name is Doug Foster. My pronouns are he, him, and I am a lead care manager here on the BEST team, behavioral health clinician. I have also carry a caseload of high needs clients or clients with very complex needs. My background, I've been around for a while. So back in the 90s, started working at ran the HOPA program for Marin County, then ran all of Section 8 and eligibility services for the Housing Authority for Marin County. I moved to Adult Protective Services, and then I moved to in-home support services with the city. Went back to school, eventually got my master's in social work, and I have spent the last 4.5 years, close to 5 years, at the Stonewall Project, doing substance use management and therapy with clients with dual diagnosis issues, treating them. It's a harm reduction program, so actually working with people while they were using. And one of the wonderful things I liked about working there was learning to treat people while they were using, not asking them to stop their use by themselves so that they could get treatment. They could come in and we could work on getting them to that place. And I think that really helps in this particular position. Day-to-day, do you want to go to day-to-day stuff, or?
Maybe we'll pass it over to Sylvia.
Sylvia, yeah.
And yeah, she can introduce herself.
Good morning, everyone. My name is Sylvia Chavez, and I am happy to be a peer counselor. I'm a community-based contractor, peer counselor with RAMS. And my experience is that I have more than 15 plus years lived experience working with the behavioral health system here in San Francisco. So it gives me an expertise as to what many of our clients are going through. Prior to working with RAMS, I worked for Clinic by the Bay, which was a nonprofit clinic that gave services to the undocumented folks of San Francisco. And I was very proud to be part of that organization. I think I'll bring it back now to Doug, who will talk about our day-to-day. Thank you.
All right, thanks everybody. Yeah, they wanted us to present you with what we do on a day-to-day basis. I just thought I would give you a bit of an example of kind of a typical day. There's almost no typical day, but there are some things that we have that are sort of baked in. We have a morning huddle because our outreach is out in the community. And we actually go out to clients with our aggressive outreach approach. We huddle in the morning. It allows the team to get together. Like I was able to raise that I have an issue with a client that I need to discuss in this morning, so I'll be taking care of that later. But if we also need help or something like that, it's time for the team to be together and work on supporting each other. And then personally, I come in and I do a chart review on my clients. It's often a way for me to find out what's happening with my clients. Clients may not be the easiest to get a hold of. They may not have devices to get a hold of them. So often my way to speak to somebody is to go out and visit them or try to find them. So clients don't always have email addresses. An example is I signed a client up for services, and the client gave me an address and asked me to communicate with them through letters. So I will be writing and mailing letters to this client, as well as tracking the client on through their chart through Epic. And what that allows me to do is if the client is actually engaging in services, I can find out what's happening if it's on Epic, or if the client may be using services, might be in, say, psych emergency services, emergency room, or in a hospital somewhere. I could actually go and visit the client. And that helps me plan my day. Last Wednesday, I actually had 5 outreaches in that particular day. I went to visit a client to escort them to substance use treatment. Unfortunately, the client was not there. Then I visited a new client to sign them up for services. I had a psychiatrist call me for a client that had not shown up, that they were concerned about, and I was able to go and the psychiatrist was able to have a session with the client at the client's home on my phone. I visited another client and was able to at least drop off my information with them and start the process. And then I went from, this is all in South of Market, and I was able to walk up to the Tenderloin to visit another client at their home. And it turned out that they were not there, but that was a useful piece of information for me. And I will say that in between this, I do have outreach that I do to clients that are unhoused. so part of the outreach is to go out and look for them. So I was able to go on the corridor from our offices are at 1360 Mission. I walked Mission to 6th Street, then I walked up 6th Street, then I walked past Glide, which is a place where a lot of people hang out, and through the Tenderloin to visit another client. But while I was walking, I was actually on the lookout for clients that have said that that's the area that they hang out in. And then there's more mundane stuff around meetings and paperwork, but that's a typical day. Will include a lot of being out in the field for me. And I did see 5 clients, but I had one day recently where I saw one client. We made multiple medical appointments in the same day, and it was a 6.5 hour. I spent 6.5 hours with that client that day. Do we want to move on to a little bit about a client story very quickly? So I was asked to present on a client that I've been working with. I started here about 6 months ago on Monday. And so I have a client who has a substantial history of being unhoused over 10 years, very high user of ED services, has complications with substance use disorder, health issues, both physical, mental health issues as well, that complicate their ability to engage in the treatment system. And they also have legal issues that are very complicating for who and how they can engage. They are actually not able to participate in certain services because of those past legal complications. And through being able to go out and engage with the client in the hospital, when we first actually encountered the client, we transported them to a substance use treatment program, which was not able to enroll the client, and the client went back to the street. And actually, Coy and I went out and wandered the street, and we actually found him in a doorway, and were able to engage with him there. And that started this relationship. The client has actually been able to be housed at a substance use treatment program here in the city, and has been doing fairly well. I've been able to connect the client with a number of services, and really I'm responding to their needs. Sometimes their needs are minimal and I don't have to visit them much, but this is the client that I spent the 6.5 hours with, getting them to their medical appointments, which gave them connection to medical social work, a psychiatrist, and their primary care provider, which were huge wins on that particular day. But I built a relationship with this client. And one of the things that I was able to do, the client, their mental health issues make them often very anxious, and their coping mechanisms are substance use, and it also it'll push them to leave the program. So for the 2 weeks leading up to their medical appointments, this last time, I visited them every day, and if I wasn't able to visit them, I enlisted the help of Sylvia, who was able to go out and visit the client as well. So I just want to mention that a large portion of my clients have substance use disorders and mental health disorders. They've often been around the system or through the system quite a lot. I have clients with over 150 engagements with the city, or the services in the city that are listed, and in some cases their behavioral health issues have led to them being having limited options as to what they can engage in anymore. So I would say that one of the things that I do is I help clients with limited therapeutic interventions to help them be able to engage in the kinds of services that are out there. I transported a client from the hospital to substance use treatment. It turns out even other people have been trying to get him for 3 years to enter treatment. And just as we were driving around in the cab, he started mentioning that he was very anxious about going and some other issues. I was able to sit with him and work through those issues, and he actually successfully entered the program. So that is a small synopsis of like a particular client and what I do for my clients, and what it can take. It's very labor intensive, I will say that. I'm seldom on the phone because I'm usually out in the field, to be honest with you, to do what needs to be done. So I'm visiting clients where they are. This particular client that I'm talking about, the client ended up being hospitalized when I had set up a second phone interview for their social security, and we were able to complete the social security interview on my phone in the hospital. So I'd say that's I'll just leave it there. And Sylvia has been very instrumental in helping to be able to work with this client and help this client meet their make their appointments to take care of their issues that they have. So with that, how about if I turn it over to you, Sylvia?
Thank you, Doug. I just want to share with you that I am rather new to the team. I've been here around 2 months, but what I have done in the 2 months that I've been here is work with various clients in various scenarios, like assisting them going to DMV, taking them to get their medications, just doing check-ins, being a source of support for them while they're on this journey right now, letting them know that they're not alone, that they're being supportive, and when they call, we answer. And we do a lot of work out in the field. The client that Doug mentioned, I had the opportunity to visit him several times to give him support when he felt anxious, so he wouldn't leave his care treatment. We go in there as needed to provide a source of support, to listen, to just be an ear, also to hear them, also come to terms with what they now know may be triggers for them, and we're able to just be a listening ear. I found that the best team is very supportive, very person engaged, and we have a lot of work to do, but they're very dedicated individuals that give this work. Thank you.
Thank you, Sylvia. Thank you, Doug, for sharing the client story. I'm going to pass it over to Coy, who's going to do just a wrap up for us, a summary of the teams and priorities and services, and then walk us through some of the themes and lessons learned. And then I think we're going to take questions.
Thanks, Doug and Sylvia. So what Doug and Sylvia described is basically what the core of our work looks like. So when we have a referral or case referral, we assign it to a lead case manager. But again, that's not the only individual, it's the whole team. As Doug say, like if in our hurdles, there's conflicting appointments or, someone would volunteer to take on that role. And also because of the high touch, sometimes I might Doug notice, it's like you can see a client twice a day, or also like once a day, and then contacting providers that same day. So we're really about high touch, meaning we're gonna do as much as we can to engage, go where the clients are, literally on the street, to the treatment center, placement, shelter, engaging whether, if they leave the placement, we go to hospitality house, anywhere that we can have access to, of course, making sure that, we keep to HIPAA compliance, but again, just making sure that we go to area that we know. And one of the key things we always ask is like, we go back to previous providers and also ask, do you know where this person might hang out, or reaching multiple agency or providers. And that's part of the sort of outreach. We don't just give up. We keep going on keeping the case open for a couple of months, even when the clients consent to services and gets is far out. We still go and engage with the clients. One of our priorities is to stabilize the client in the community, whether that's placements. I've described that situation where we do transport people from psych emergency services, from inpatient medical, psych inpatient. We transport the client literally to the placement, and also if they need to be connected to mental health, because again, a lot of program are not able to do dual diagnosis, we provide those short-term bridge services, connecting them to long-term mental health services. One other thing we want to focus on is like, we might have an idea what the client needs, but we ask basically, what would you need at this moment? Sometimes like people just say, need food, I just need my ID. So we start from there. But we connect and link people to mental health services, substance abuse services, primary care, housing support, any legal services. I'm not repeating a lot of stuff, but basic needs like getting an ID, going to GA with the client at 8 in the morning, at SSI using our on-phone to put on speakers so that we can do interview over the phone. And I think Doug did it in treatments. Of course, it's about privacy, but asking client what they need. Let me see. We literally will work with the client and making sure that basic needs are met. One other thing we also do is we just don't want to don't close out the case just because the client is linked to a program, whether it's behavioral health and, or substance. We keep the case open and making sure that multiple time that the client has already been engaging and seeing the therapist or psychiatrist or whatever the providers before we close out the case. Meaning, but we technically don't ever close the case. They can always call us back for a consult. And going back to one of the things, like kind of the theme, rapid response is really first critical. What we do is also before the clients are discharged from the hospital, we actually go out before and do a face-to-face contact, getting to know the client before they get discharged, and we actually do transport client to wherever that placement is, because this is my face. Sometimes I have to, when you go to the hospital, I pull my mask down to say, hey, this is me, so you can tell me, and just asking, things of like, where would I be able to find you? Because a lot of time, placement, the client would go to that placement, but sometimes it doesn't work, but we always want to try to engage. As Doug say, outreach is really time intensive. Most of our time is out engaging with client or locating client for services. I know we know a lot of our client consent to services, but maybe they're not ready, but we just keep going and making that contact. Engagement, like we all know, is really persistent, and we need to we have our idea what the case plan or treatment look like, but we have to make sure that the clients want or need that services, and basically basic stuff. I just want an ID. One of the client I have is I just want a male provider. So basically asking the client what they need and the barrier, they will tell us the barrier. A lot of the client already know what they need or been through it. They teach me every day. And one of the things that I think is nice is for self-care for our teams, we do collaborate with each other. We do share going out together, or if we were overwhelmed, you consult with your supervisor, your peers. And I think that's why, the case that Doug and Sarah talk about is there's time Doug had to go multiple times during the day, literally to that placement, receiving that phone call and he's doing something. Hey, Sarah, can you go over there to kind of talk to, make sure that the person can stay in their placement. So ultimately, I think for us, what I like about the bridge engagement team is that, we talk about team, but we are really trying to kind of support each other. And Doug, do you want to say anything else I missed or Sylvia that we talk about?
I think, this feels, unless Doug, you want to add anything, this feels like a really nice summary, and I know that we want to leave some time for questions and discussion. So, okay, all right, well then we will pause there, and I just want to thank you all for presenting your work. And yeah, we wanted to leave lots of time for questions.
Thank you so much. You all, that was amazing work. I think the first question I think that I have is just to understand the caseload of what that actually means when you're working on a team. So do you assign to individuals, or does a whole team or a whole pod have sort of a whole case load, or how does that really work? Just so I understand. And then I have member Salinas. Oh, you had your hand up. Do you still have a question?
Uh, as to the case assignment, we have a lead case manager, meaning that the person could run the show, but also they can delegate, meaning I just used to get delegate, but ask other team member to support. So there's always going to be one person who is the main. So we won't like, oh, we have 10 people and you're going to say all 10 people. But what we do also is not to, like making sure before we say, hey, can Sylvia go out for me? Doug would like make sure that, we team and go out and meet the client and, hey, this is Sylvia, she might be, she can be helping me. So we just don't throw people out like, oh, hey, I'm not here, you're gonna go out tomorrow. So it's like, we want to make sure that there's a phase to what we do and just not like, oh, 10,000 people coming into a case.
Beautiful. Thank you so much, Coy. And I know I've met you somewhere before, so good to see you. I have member Salinas and then member Eisen.
So quick, what is the caseload size per case manager? Like, is it 5, 8? You're on mute, Coy.
Okay, can I defer to Heather?
Sure. It's the plan is for it to be 10 to 12, so that's about where the staff are building up to. I think almost there right at this moment.
Actually, we're almost there.
Yeah.
So, and is your program considered, so it sounds like it's an act, like you're very much running on like an ACT program model. Is that accurate from the description of what people are talking about? Sounds like an ACT.
Yeah, I mean, in terms of the intensity of the service and the focus on connecting to everything, I think yes, and it's definitely not long term. Really, it's intended as a bridge, and it doesn't have the kind of ACT community focus. I'm losing the words, but like a milieu. That's the word I'm looking for.
I see. Yeah.
Yeah.
All outreach. There's only the outreach and the sort of the structure, how you're morning huddles. That's very typical ACT. Yeah.
Yeah. It's very field based.
So are you guys technically then, you are specialty mental health? I'm just wondering, so like, is there, so how are you guys working, how are you guys aligning along the spectrum of the short-term linkage programs? Is there a lower, it sounds like though that maybe there's a lower threshold for being able to engage and do, like folks aren't actually having, you don't have the same Medi-Cal barriers around. Folks have to actually consent for services before you all can start doing case management things for folks. Is that accurate? Is that how this is? It's a lower threshold in that way for this program?
It is lower threshold, definitely. We do get consent because that feels like an important thing to do.
Right.
But it is lower threshold, and we do some of the interventions are actually very short, so they're really geared towards what the client needs, and they may be in conjunction with other teams or other treatment teams that the person has been connected to but needs extra support to get engaged with. So it's designed to be very, very flexible in that way. I think some of the case that Doug presented, initially Doug and Sylvia were the people, but as more team members get added, they will eventually kind of take over the primary treatment.
Oh, so you guys can be open at the same time. You can open someone for services at the same time as they're open with another agency.
Yeah. And what I would say is that we're not. Oh, sorry.
And so it's not considered a duplication of services.
Right, and we're really trying not, to hand over and not be operating jointly if it's not needed. If it is actually truly a duplication of services, but there are many cases in which we're actually just supporting and enabling the engagement in services. So yes, and we're also, I should say, I'm sorry, did I say this earlier? We're not, we're not specialty mental health. So we're connecting people to both mental health and substance use treatment across the spectrum. So people with co-occurring disorders, people who need much more substance use treatment, people who need much more mental health treatment. Obviously, we want anywhere anyone gets connected to be able to provide both. But we are really trying to connect people to the behavioral health continuum as a whole.
So you're not technically ICM, but you're providing like short-term ICM-like services? Is that, or are you
Yeah.
technically ICM?
No, yeah, we're definitely not technically ICM. But ICM like, yes, absolutely. Absolutely. And I think sometimes we are, that is the level of service that we're providing, if that's what's needed in that moment.
So if like there's a wait list for the other linkage programs, is that like that's where you guys will come in, or it just depends on the particular client's need?
It depends on the particular client's need. I mean, certainly this is adding to the capacity in the system, and you know, ideally there will not be capacity issues, right, in our ideal state. And so I think best focus would be on people who really truly they need much more flexible engagement, and need this this kind of level of outreach and engagement, and who may not meet specialty mental health criteria because or we don't know if they meet social mental health criteria, may not have reached the ICM threshold. I mean, there are many examples, I think, but I think what we are doing right now is helping to ameliorate some of the capacity issues for sure.
So there might even be some folks you guys would pick up and then transfer to like the TAY acute linkage or to our linkage. Like you might pick them up initially, and if they need more stabilization, then they would come to our.
Yeah, that has happened. In particular with the TAY.
Member Salinas, I'm getting this sign. Are you feeling somewhat complete of where you're headed? That's not okay. Thank you. I apologize.
Yeah, I was just trying to figure out how y'all were going to fit into the spectrum of
Got it.
our.
No, I appreciate your questioning, because I was trying to figure out the same thing too, and how the charts and the billing and all that works from the administrivia perspective, but also then how does the client link to more long-term services. So thank you for your questioning. You have another job as a legal person. I wanted to shift to.
I don't want to be a legal person.
Okay, don't. A Socratic method. So please, Member Eisen, then we had Member Wong and Member Fields. And then we are going to take a break. So please, Member Eisen.
Thank you. So if you're placing a client into any kind of a residential setting, be it a dual diagnosis or substance use or mental health treatment setting, do you work with the program in advance, during, and upon possible discharge to assure that the client is like best set up for success and there's a plan for how to support that particular client's needs?
I can, yes. So basically, a scenario would be like, we have a case right now, the person has both dual diagnosis, but there is in a substance placement. So we would be kind of the bridge for mental health, and then making sure that they go to the mental health services. Yes, so I guess our answer would be yes. We work with the person in placement, and also coordinate and collaborate with the treatment program before discharge. And we will, again, it's short term, but we want to make sure that a plan is in place. We're just not going to leave the person and say, hey, you're in placement, now we can go. So we will handhold. And again, we're the extra support because, you know, I hate to say, but we didn't have the luxury of being in the field. So we have, you know, time. I wish we had more time, but we do have the ability to go out in the field, go with the client, go into providers, which I know a lot of treatment center or any like clinics, the staff are not able to, you know, do that actual legwork that we're able to do. I hope that answers your question.
Yes, thank you.
Thank you. Thank you. So we have Member Wong and then Member Fields.
Hi, thank you. And thank you, Heather, for giving us an overview about the best the best team. And I applaud the best staff. I mean, I think it's really hard work to really try to engage people who are out there and who may or may not want treatment. And, you know, I think part of it, I was thinking all along, I was taking my hands up, putting my hands down, you know, and it was along the line with Member Eisen. It's like, you know, with kind of ICM stuff, along with Member Salinas as well. It's like the type of work you guys do is very much ICM, and so you know, how are you guys going to fit in and then work along with the existing programs? I'm always referring to the existing programs and then existing care providers, and I know that you guys launched in 2022, and I'm just kind of curious as to, you know, since your launch of the program and your team's work, what kind of success rate that you guys have placed, you know, hearing such laborious tasks that you guys do, what's the success rate of placing these folks, these difficult folks that are hard to engage and who have complex needs? What is the success rates that you guys have kind of helped these individuals since your inception or since you guys have launched the program?
I think I will, so I'll respond maybe to two parts, and thank you, Member Long, for the questions. In terms of how we fit into the continuum, I mean, this Bridge and Engagement Services team is really meant to be kind of care management and connection to services, connection to behavioral health services, not intended to be treatment providers in the same way that ICM contains this treatment element and is a treatment provider. So we are really focused on working with people who have had a hard time and need some extra support getting into our continuum of care, which includes ICM services. I think what gets tricky about explaining that is that some of what we're providing, and especially right now when there's a wait for some wait for ICM services or some work that needs to be done to get into ICM services, is that the team is providing ICM level care and kind of holding that in the moment. So we are on the side of, in terms of the system and the continuum, helping to bridge people into the continuum, but not necessarily as the long-term treatment providers. And to the second question, I'm very excited. I think this relates back to our EPIC question. Very excited that EPIC is going to allow us to really start digging in since the launch in January, and really, you know, we've been growing since then. But this team has been providing services now, I guess, you know, a little less than a year. That we'll be able to really start digging into some of that data to look at the quality of the connections that we're making. I'm curious if, Boy, you know, if you have anything you'd like to share anecdotally, but we look forward to bringing back more data in the future as we start getting that into EPIC.
Yeah, I think Heather, thank you. I was thinking about that, and I mean, I'm a bad math person. Numbers really hard for me, but I did have an example. I was thinking we had one young gentleman who was circling in and out of psych emergency services, non-stop. I mean, I shouldn't say non-stop, but in and out, but was never admitted. We will refer that case from social worker in psych emergency services, bilingual Spanish. One of my staff or my teammate was assigned who engaged a person, and we actually, I'll just be honest, I was like, this is going to be a really challenging case, but somehow the staff clicked with this person. We made a refer to Mission Mental Health, and I'll just name the staff person. I shouldn't say staff. Christian actually went and literally took the person to Mission Mental Health for intake for this medication evaluation. And somehow, I mean, I must say somehow, but the person was really connected, and we haven't seen the person coming back into PES or any of the hospital system. But before, if you look at it, like, whoa, this person's high utilizer. And one other thing I also say is like, just because the person's connected, we did keep the case open to make sure that there's a follow-up, but make sure that they are fully connected. Because sometimes I think, I don't want to just tout off of the best team, but we want to make sure that the person is fully connected. It's not just referral, hey, I made a referral, then you're done. But we want to hold on to that person to make sure the transition is really smooth. Because like you said, the system is so huge. I'm still learning the system. So that was one example. I know I hate to, I'm trying to remember in my mind, but Doug, I mean, I know that case that you talk about is almost there and it's really intensive, but do you have any other one to share?
Oh, and I apologize. We do need to keep moving on, and thank you so much, Coy and Director Weisbrod. I have Member Fields for our last question, and then we're going to take a break. I apologize. This is all incredible work and incredible information that we want to hear. It's just we're also trying to keep on a timeline. Member Fields?
Thank you. I have just a couple of quick things. First of all, I want to commend everybody who's been talking. It's familiar language in my world, and it's nice to hear we're finally implementing the kind of, articulating the kind of approaches many services have used that have worked for a long time. I just want to get a clarification because I'm beginning to become worried, just as a practical dude on this committee. We're standing up a lot of programs that don't have a revenue source except general fund, which makes them very vulnerable when the budget goes south. And so I'm wondering maybe, Heather, if you could say a word about two things. One is very practically, what's the specific relationship with the SCIRT teams we have set up all over? There seems to be a potential overlap of individuals who are in a situation where you may be going out and they may be seeing them. And is it true this program, all the language means it's not Medi-Cal reimbursable because of its low threshold philosophy? And is there a plan with the new Cal aim changes and everything else to try and find a way to provide a financial underpinning to these programs so they can survive a budget turn down?
Thank you, Member Fields, for the questions. In terms of the Street Crisis Response team, the OCC team, which is the follow-up team, we work very closely and coordinate with them. And so there's very clear agreement on who is following an individual at any given time. So there's not overlap. There does once in a while, if somebody from the hospital is not aware or has not yet found out that a CRT OCC, for example, is following a client, they may contact us. We can assess very quickly whether they're already followed, and then we make that connection. And I should say the CRT OCC team also came with us to Epic. So they were part of our Epic launch. And that is also, I mean, that's just kind of further enabling our communication. So we feel really clear about the reach that both of these teams are allowing and the non-duplication of services. In terms of funding, yes, I mean, that's absolutely, I think, an outstanding question for us. Our goal is to launch and start providing services. We are a CalAIM enhanced care management provider, as I mentioned, I think earlier on, which means that we are able to get some revenue for the enhanced care management services. And then certainly are always looking at possibilities for revenue.
Thank you, Heather. Thank you, everybody, for your report. Another promising intervention. Let's see how these all start fitting together somewhere. So thank you.
Thank you, Member Fields. Well said. So I believe we are, should we do public comment before the break? Is that what we're doing, team?
Yes, please.
Okay. Please, Ms. Sadka, take us to public comment.
All right, so those who'd like to provide public comment on this item can call 415-655-0001, access code 2485-747-7444, then press pound and then pound again, and then dial *3. Let's see if there are any callers in the queue. Currently, no callers. Want to wait a little while longer? Since there are no callers in the queue, I'm going to close public comment, and I think we are going to take that break.
Great. So we have a 5-minute break. Let's go from actually from 11 to 11:05 and call us extra 2 minutes. So see you at 11:05, everyone. Please remember to turn off your cameras and your mute and turn them back on when you're back. Thank you.
Are we going to one today?
Till 12 today is the plan.
Okie dokie. Then I don't have a
Yeah.
problem. I have no conflict.
Awesome.
Thank you. Okay. Thanks.
Love to hear it. Thank you.
Okay.
You look all bundled up.
It's chilly. I'm working from
I
home
know.
today, and it's the basement, so
Yeah, it's chilly.
yeah.
Okay, see you in a few.
Thanks. Bye.
Welcome back, everyone. Thank you so much for a great morning. I know we're all wanting to stay focused so we can abbreviate this meeting a little bit because there's so much work to do. I am wondering, Ms. Dodka, do we have quorum?
Let's see. I believe so.
Wonderful. So we are now moving into our December implementation report, discussion group report out. And I guess this, I think is supposed to say, is this supposed to say December or is it supposed to say November? Or you mean for the December implementation report, the discussion group?
Yes.
Got it.
Yes.
Got it. Okay. So at this point, we want to thank first off members Field, Lipton, and Wong, who convened this past month, along with Ms. Oksana Sherba, I believe that's how you say it, from the Controller's Office. We invite them to present on this discussion now.
And I'll kick, this is Jen. Hi, everyone. I'll kick this off, and Oksana would appreciate if you had some additional feedback for the purpose of the report. We presented this last time, and just kind of to pull out, like, this is the only implementation report that is a legislated requirement of this sort. So it is requiring by June 1, 2021. So all of this has been delayed because of COVID. But we are required to submit a set of recommendations covering the design of mental health San Francisco and any steps that may be needed and required to ensure its successful implementation. So that comes from the legislation, and from the last time to this time, we it was due at the end of November. The revised date was due at the end of November, and now we have an extension until December. So we have a little bit more time to work together to make sure that BHS has a chance to participate in this process and lend content, as well as the IWG, and bring those two perspectives and orientations together. So and I just wanted to highlight, like, the experience that we've had over the last 2 years has been, is like, when you think about what this report is, it's almost like a linear process. Like, we would develop all these reports or all these recommendations, then they would go in a report, and then you would implement it. But that's not how this has worked, and it's really not how it probably even, it shouldn't work in this way regardless, because the services need to be on the ground and need to be working instead of waiting 2 years for some kind of an implementation report. So what we're doing, and what we've done over the last 2 years, what we've done over the last 2 years is we've developed a series of recommendations for all of the components. Some of them have started to have run into implementation. Some of them have been coming back and giving you updates. And this is an opportunity for all of us to be able to reflect on how those recommendations have been developed, what has happened with those recommendations since they've been implemented, and then where the future of the IWG is going to go. So it's a really great reflective opportunity, and we're taking this extra time that we've been granted to really bring those sides together and to make sure that we have a full and comprehensive understanding. Oksana, is there anything else that you want to add just from the legislative side of the House?
Nope, you got it all. Thanks, Jen.
Okay. So the way that we have been handling it is, now that we have this extended timeline, the goal of this December implementation report is to ensure that this is co-developed by IWG and BHS. So we want to make sure that we have kind of a comprehensive view, that everyone is looking at what we've done together, and that we have an opportunity to reflect on it and to set a path for the future. So since this last meeting, since our meeting like 2 weeks ago, we've divided the report into 2 sections. So the first section, which is part 1, is reviewing the progress of the IWG. So that's really looking at the recommendations that we have developed over the last couple of years. The second part of the report is going to be the future of the IWG. And that's really thinking about, like, what does the IWG want to become in this next stage? What does BHS see as the opportunities in this next stage? So what we did is, because of time as well, is that we split them into 2 parts. So right now, BHS and DPH is providing some initial response to the recommendations. So we collated all the recommendations. We went through all of the different meetings. We put them into some tables that are kind of understandable. and now the different teams are looking at that. They are going to be submitting that to all of you, the IWG, on December 1. So on December 1, you will get those tables of what has happened for each component for Mental Health San Francisco, and you'll have an opportunity to look at it for a week, get us any kind of feedback, changes, questions you have, and we'll bring that back to be able to be part of the December 13th meeting. So that's part one. So BHS and DPH is taking the lead on that. They're going to get you feedback. You'll have a chance to respond, and then it's going to come back for a group discussion. On the other side, for part two, for the future of the IWG, the discussion group has been meeting, and they have been, oh, thank you. Thank you for that. The discussion group has been meeting and has started to flesh out some of these ideas of what the future of the IWG can be. So at the last meeting, if you recall, there were 6 opportunities that the discussion group presented, and then they met again in between last meeting and this meeting to flesh out some further points about what those 6 opportunities are. We're going to hear from them in just a couple of minutes, and so the whole IWG will have a chance to see what they talked about and what they're bringing forward and to offer some additional feedback. After this meeting, that response, your response, the IWG's point, is going to go back to DPH and BHS, and they're going to have a chance to look at it and respond to it. And then they'll be bringing that response to December 13th. So by the time we get to December 13th, all of the recommendations have been looked, touched, and reflected on by all parties. And the future of the IWG has been looked, touched, and reflected upon, and we'll be able to bring it together for a full discussion at December 13th for submission to DPH for an ultimate decision or submission to the Board of Supervisors, the mayor, and the director on December 27th. So what you see on your screen, that is the simplified process that we're going to use for what I just discussed. We're going to hear from the discussion group next, but I wanted to pause before we go to the discussion group and see from the IWG, are there any questions about that process that I laid out, or when you're going to get things, or when you'll respond? Member Salinas, is your hand still up from the last one, or did you have a question about the?
I think still up.
Okay, thank you. Okay, I'm seeing no hands, and I'm
Sorry
hearing
about
no.
that. Sorry.
No worries. Are there any questions or thoughts about the process that we're putting in place to co-develop this report? Okay. All right. If it occurs to you, jot it down and we can come back to it a little bit later. So the famous Steve Lipton of the Steve Squared group is going to be presenting on what we talked about at our discussion group and get your feedback. Steve?
I do it mute. Well, good morning. I unfortunately was handed the shortest straw by my fellow discussion group members, and making what is the presentation. So at the at our meeting in October, and it was discussed at the IWG meeting, we identified what we consider to be 6 opportunities for the future of the IWG. Which is on the slide, and we're going to go through each one of them, so I'm not going to read them. I do want to make one comment that items 1 and 2, which is the focus on system of care and shift from responsive to strategic, are what we kind of consider the foundational opportunities from which items 3, 4, 5, and 6 are follow-on or kind of devolve from those. And those first 2 opportunities are based on the recognition that the mental health SF ordinance was intended to be a broad transformation of the system of care rather than just discrete components of care. And so the overarching view of the discussion group is that we ought to be focusing on the big picture and try to get away from looking at discrete programs. So and make this a better use of our time. So let's move on. We can walk through each one of these. Let me ask the chair whether you would prefer that we take each item one by one and then have discussion, or go through the entire set of opportunities and then have discussion afterwards.
Thanks, Member Lipton. Let's go through everything and then we can pull it apart after. Thank you.
Okay. And I'll say at the beginning, I think we've taken, the discussion group has taken a pretty strong approach. And I think this would be an excellent opportunity for members of the IWG to kind of weigh in and see whether we're all on the same page or not. And I'm sure if we have some issues to resolve, we have Jen to facilitate that. All right, so item one is the system of care focus. And what we want to set forth in the report is that we want to move from shifting from advising on discrete mental health SF projects to focus on the bigger picture, particularly how do all of these components fit together in a coordinated delivery network. Secondly, a real focus on how do mental health SF clients navigate the system of care issues, barriers to access, wait times, client focus, culturally competent services, et cetera. I think that our last agenda item on the bridge team was really an excellent segue to what this opportunity represents. And this is pretty, this is, I think, where we really want to be focused on. So that is opportunity number one. Opportunity number two is strategic focus. This, to some extent, goes to our agendas and the kind of the topics that we take up. And it's got two items, one of which is that we try to get away from commenting on the design. We have to continue to comment on the design of system components. We still have a few outstanding components that are not online, particularly the Mental Health Service Center, but that we ought to be looking more towards advising on broad program elements that come out of these various domains. And one way to do this is to decide whether we should have, how we want to use discussion groups and subcommittees. And as part of this discussion, Jen and I both had or shared emails with the attorney's office. There are some Sunshine Act and Brown Act issues in terms of public meetings. I don't think it necessarily will crimp how we do this, but one opportunity is to see if there are members of the IWG who want to do a little more in-depth focus on some of these issues and use that in between meetings, then they can come back to the full IWG. This is really more a function of the IWG strategically identifying where we want to go, as opposed to having the department or others determine what our agenda should be. So that's item two, to shift from being a responsive body to a more strategic thinking body. Number three is to try to define a little better what will be the accountability of the department to the IWG. Again, a focus on system of care accountability more than just program accountability, particularly a discrete component of the program, as opposed to the bigger picture. And that, I think, and this may require a subcommittee or a discussion group to try to define what we believe should be the IWG's sphere of influence and the level of decision making. Again, the ordinance says that we are to advise on the design, outcome, and effectiveness of mental health SF. So we're really looking to do a stronger focus on the word advising to guide our next stage of a relationship between the IWG and the Department of Public Health. we can come back and talk about that further. Item number 4 is one that is going to continue to, I think, vex mental health SF and the IWG and the department, and that's going to be the funding base. And that there needs to be more focus on what kind of funding streams and opportunities there are, because Prop C is likely to continue to have shortfalls for the foreseeable future. And so we should be looking at maybe more state funds, maybe Medi-Cal reimbursement, other revenue streams. This is something that we'll have to do in concert with both DPH and with the controller's office. But I think we want to get a handle around the connection between the growth of mental health SF and the budget. Number 5, this has been as most of our meetings have evolved around recommendations for specific programs. We've had a series of members who have had to conflict out of having providing comment, review and comment. In some cases, we may have had some of our most experienced members or members who have specific experience who've not been part of that recommendation process. And that may have, in some cases, affected what the recommendations are or how well they've been received. But any event, I think the idea is that as the IWG becomes more strategic and looking at the bigger picture, that should ameliorate the concern about conflict of interest. Because we're not going to be dealing with as much with a specific program. From time to time, we will have conflicts, but at least this will give the IWG a more fuller participation of its members. And finally, I think this is an area that we have not really fleshed out a lot, but I think really needs to have some discussion, is how do we increase the voice of those with lived experience and providers and others to provide guidance to the IWG. I think there's been some concern that now, as we have public comment, we don't really address a lot of the public comment, and we haven't really affirmatively encouraged trying to have different voices give us feedback. So this is something that might be done either in a IWG setting or in a subcommittee, a full IWG setting, or maybe a subcommittee setting. But we ought to try to get not only get updates from the department, but also hear from the community and how that informs us in the work that we're going to be doing. So that's really a hop, step, and a jump through the 6 opportunities. We'll have to figure out how to incorporate these into a report, but that's kind of where we are. And with that, I will stop and open it for discussion.
Thank you. I'm looking for anyone who's ready. I see Member Fields.
Yeah, as one of the folks, as Steve Lipton isn't completely blamed for anything that might be in this, I think. I just wanted to weigh in a little to underscore what I believe in our fairly lengthy discussions was behind this that Steve's also laid out so well. But what I think we're trying to present to the working group, everybody who's been in this for so long, is that the way events unfolded with the IWG getting formed late in a process that was already developing as a crisis on the streets from the perspective of the Department of Public Health and a legitimate perspective. In a way, the Department of Public Health did what they're supposed to do. They began to move to address visible needs in the community in the context, a sense of mental health SF, For instance, the skirt teams being already set up before we were even impaneled. I don't have a beef with that process. I think that was driven by events, including how late we were impaneled as a group. And then what I think we fell into as an IWG and with the department as well was looking at only one element of mental health SF was to describe a couple of very key components that currently did not exist in the system of care that were going to be important in a comprehensive plan if we were getting anywhere. And we were brought into a point of just hearing the development of things rather than really being able to be involved in a discussion. I think many of us feel that this crisis stabilization unit discussion and the center looked more like being involved early with the department bringing stuff to us than the previous kind of rolling necessity was. And of course, we had the implementation of the emergency condition and the tenderloin, and we had the which included as a major component to it the fact that people, citizens of our city, were dying from overdoses. So we were caught up in what is the role of the IWG in trying to implement the intention of the legislation. I started my work politically, even though I was always in San Francisco with the state legislature, and I learned something very important. Always go back to the enabling legislation to try and get a sense of what the intent was. And the intent wasn't simply to address homelessness on the street. It's very, and I recommend, I don't know if everyone's had a chance to read it again, but it's very clear that we are charged as a city with addressing the need for a comprehensive system for a broad range of citizens, the homeless, the uninsured, those enrolled in Medi-Cal or Healthy San Francisco. So we have a broader mandate. It may be more than any organization can humanly do, but that doesn't mean we get down into the trees all the time instead of looking at the forest. It doesn't mean that we're looking at different elements being developed to respond to a crisis without a comprehensive overview. And from my point of view, I don't think the IWG has initiated enough of a discussion around what is the call in this legislation, which is clear as a bell, for a reformed, comprehensive behavioral health system for citizens of San Francisco. That means housing for people coming out of jail because the opportunity is there and the necessity is there, but it also means how do we get to a more of an investment in early intervention and prevention. That's a system of care. And so what we're saying is we think that the group would like to get a balance back. Yes, we do need to advise and be involved in the way individual elements are being developed in the system, but we also need to stay focused as well on our necessity to look at the other. Section 4 of the legislation is very clear. It's not just a center and a crisis intent and case management services. It's very clear about developing a comprehensive expansion of community-based services to serve people. And as we've seen this morning, we're already losing some of our existing system of care. And we need to be engaged in looking at what goes from crisis intervention that takes us to stability in the community. And I think we felt we need to start talking about that with the department. What is the ongoing plan in the midst of crisis and everything else to take that very important but very small section of the legislation, section 4, that says we're going to expand and make recommendations on the expansion across a lot of modalities on the entire behavioral health system of San Francisco, including the recommendation from us, as well as interacting with the departments on programs that we need and services that we need to achieve the goal of this legislation. And this, to me, my belief is this discussion and these things we're talking about is an effort to add an equal weight in our deliberations, discussions to the implementation of the expansion of our community system to meet our goals more effectively than we're doing now. Thank you.
Thank you, Member Fields. I'm looking for other hands, and I guess what I'll just ask is, how do you all see these 6 opportunities, especially the 1 and 2 pieces? How are they actually operationalized in what content of meetings and whatnot? Just so that I'm making sure that I'm understanding really what you're asking. And then I see Member Salinas's hand after that.
Well, I guess I will try to answer that to the extent that I can, and I think others may want to weigh in. I think that one thing we should be doing as a body, and I'm not sure how we'll do this, but I had suggested at a prior meeting that maybe we need a retreat or some type of extended agenda discussion, agenda item discussion at some point, maybe after the beginning of the year, where we can talk among ourselves about kind of where we want to go and how we want to get there. And this is one of those items. But I think the idea is that the IWG should be more proactive in selecting the topics that it wants to have discussed at meetings. And once we have some consensus around what some of those topics might be, decide whether we do that as an entire IWG or whether we use a discussion group or an ad hoc subcommittee or some other means to kind of tee up these issues for the larger IWG. But I think the fundamental part of this is that the IWG will become more proactive in setting its agenda than having its agenda set for it to some extent by the various items that have come before us from the department or from the controller's office and so forth. Again, this does not mean that we stop making recommendations. It doesn't mean on new programs. It doesn't mean that we do not want to have reports. I think we want to continue to have reports from the department. It just means that as we structure our agenda, we make sure there's adequate time to focus on the bigger on the big picture and not get not consume too much time or much of our time on specific program recommendations.
Thank you, Member Lipton. Member Salinas?
Thanks, Monique, for that question, because that was something I was thinking about too, in terms of 1 and 2. That I agree with these 6 opportunities. But I guess I would come back to that data that I think that we really need data, right, on our system of care, which I think has proven a bit daunting for the department, not having the staff, as Dr. Kunins mentioned. I remember the analytics staff, I think, was supposed to be hired by the beginning of this year, and here we are in November, and they haven't been able to hire, and that's not fault of BHS, of course. So but we do need a lot more data that we've been asking for all along, so because we want to know, like, where are the gaps, right, that we should, I think that's where the strategic focus would lie, in looking at, right, the system of care and where are the gaps, and we haven't been able to get that data. And so then I guess what I'm wondering is, since it's been very difficult to hire analytics staff, I'm wondering what would be the possibility, and I guess this would be something to address, with folks over at BHS. I don't know whom, but what would be the possibility of hiring at least a contractor, maybe we have money, some, with that, not having hired that analytics staff and having to pay salaries all this year, could that money maybe go to just hiring a contractor just to do an initial evaluation, an outside contractor to do an initial evaluation of the system of care, and where are the gaps, what are the wait times, all this data that could help us to have more of that bird's eye view. And then maybe, yeah, and we can proceed from there, and maybe it'd be easier to hire analytics staff when they already have. Maybe the task seems very daunting to folks, and that's why I don't know. I'm just making assumptions here, but maybe I think at some point we have to, if we're not able to get analytics staff, we have to look at hiring a contractor at least to do an initial evaluation of our system of care and answer some of these questions that need to be answered.
Thank you. I think I'm actually just going to poll our members to hear what other folks say. I'm wondering, Member Gonzalez or Member Eisen, would you be ready to speak a little of your thoughts?
And Chairless, James McGuigan has his hand up.
Oh, great. Member McGuigan, do you want to go ahead, and then I'm gonna let you all know I'm coming to you to get your input.
Good morning. Thank you, everybody. So just on the strategic focus, I would love to see specific subcommittees started. I really think one of the two areas that I'd like to see is what could we do to help recommend and get, a lot more case managers and, better pay and retention for said case managers. I think that's the biggest area that's lacking. And along with the analytics, to look at that and then make our recommendations and really try to focus on that so people aren't getting lost. And then even just subcommittees to, either on like a quarterly or bi-monthly basis of, making some site visits and talking to people and looking at places and saying, okay, what is working here and what's not? Those are some of the strategic focus I'd like to see and be a part of. So I definitely think that instituting specific subcommittees for area focus would be a great idea.
Thank you, Member McGuigan. Who's ready to go next, or I'll start to call?
My hand's up.
Oh, great. Please go ahead.
First of all, I really like Member McGuigan's ideas. I actually think making some site visits to places might be a wonderful idea, and it gives us an opportunity to maybe get some consumer input directly. And also focusing on worker pay. I know that committee is the work group's about to meet, but I think if you mapped out gaps in the system of care that had to do with unfilled positions, it would be startling. It would be quite startling, both on the DPH side and on the community provider side. And it would give a great picture of, one of the flaws in the system. I like the recommendation. I mean, I think the recommendations are great. I hope that at some point, I think we all hunger for this great big, and one of the community public comment person commented in public comment talked about a desire for this kind of the grand mapping. And I think we all hunger for that same idea of how does, particularly on the care coordination side, how do those things connect? Member Salinas, when you talk, I'm always amazed at how much you know about the different systems of care coordination. But there's many, I think, providers and community members who may be interested who have no idea how those systems interrelate and how they talk to each other. And so I don't know whether that's a strategic focus or DPH accountability, but I think that I like the direction that the group is recommending.
I'm gonna just jump in here before other members share as that a plug for y'all, whoever can attend, joining that in between conversation around the mapping. So that y'all, who I know all of you just really wanted, been adamant about like having that conversation. And so DPH can come back with like a clear vision of like that mapping. Definitely encourage folks, if you have the capacity, to join that discussion group next, I think it's December 2nd. So just putting that out there, that if you have the capacity to join.
Thank you, Ash. Member Gonzalez, do you want to chime in at all? Annie, Member Gonzalez, are you able to chime in? And maybe if not, Member Hammer, will go to you.
Yeah, just a quick comment, and really appreciate the work of the two member Steves on really thinking about this and putting it out for us to respond to. I guess what I'm getting stuck on is the first two opportunities seem to be, if I'm interpreting right, like for the first one is kind of continue as we have been with reports and responding and making recommendations, and the second two would be going really thinking about how we either in a retreat or something, but like really doing some strategic planning that IWG would do. It's just not clear to me like how that would interface with other strategic planning work that's happening at the department or in behavioral health. And then 3 through 6 seem like opportunities for specific topics of discussion and things that we could really shift our meetings to get to. So less in the way of reports, but more setting up a structure for accountability, really looking at funding and seeing if there are new ideas. And since so much of the funding comes from Prop C, which really narrows the focus of our population, sort of to address member Field's concern about population focus. So am I correct in saying that? And really what we should be discussing is 1 or 2 is whether we want to sort of go down, pursue 1 or 2, and then 3, 4, 5, and 6 would be future ideas for meetings and engagement outside of the meetings.
And Member Wong was also part of this group. So Member Wong, did you want to add in anything? And then Member Fields or Lipton chime in?
Yeah. And Chair Lasar, I just want to say that Member Gonzalez wrote in and said she is trying to connect, but something's wrong with her.
Oh no, okay.
Yeah, so maybe before we get to Member Wong, maybe trying Member Gonzalez again, seeing if we can get her in.
Oh, okay. Did you all want to respond to the question that Member Hammer asked? And then I'll come to you, Member Salinas.
I'll be happy to take a whack at it, and maybe Member Fields would like to then correct me after I've tried. Again, the first two are what we've kind of dubbed foundational opportunities, and it's really more of how we want to focus our time, and particularly given that we have limited time, we have members who have themselves limited time to devote to the IWG, and we obviously have limited resources to support the IWG, since we don't, other than Carter, we really don't have full-time staff. So I think that the main part of this is that we kind of get our hands around as a body how we want to focus on mental health SF as a system, rather than necessarily the discrete programs, either discrete programs that were called for in mental health SF, or that are otherwise part of the behavioral health program, and pick pick those areas that we want to focus on. Mapping clearly is one that has resonated, I think, with this group. I absolutely agree with the comment made about site visits. I almost every other day walk by the Ferry Building and see some of the street crisis teams having a coffee break at the Ferry Building, and I kind of use my better judgment not to interrupt their coffee break and ask them, well, how you doing? But I think it would be good to have site visits. Case management is obviously another one. So I think it's like the group coming together and say, here's what we want to do, and this should be the primary focus of our meetings, and try to get away from using half or 2/3 of our program to make recommendations, or specifically to receive reports about existing programs. We got to try to minimize, we got to get those reports, but we ought to try to balance that time against the broader picture. Again, items 3 through 6 will kind of follow from items 1 and 2, opportunities 1 and 2. And I think down the road, it may be a discussion group or subcommittee that might want to focus, for example, on the funding base. I think this number 6, well, number 5 on conflicts of interest will kind of resolve itself. Item 6, in enhanced engagement, that's the site visits, perhaps having the IWG have a small subcommittee that specifically would try to engage with clients who are part of mental health SF. But it does mean we're going to have to organize ourselves in a certain way to try to move in that direction. So I'm not sure if that fully answers your question, Member Hammer's question, but that's kind of how I think as a group that we probably see this.
Thank you. Member Salinas, no, sorry. Member Gonzalez, are you able to speak now? Maybe not.
Yeah, Member
Annie?
Gonzalez, yeah, we can see that your mute went off, but your voice isn't coming through. So,
okay, let me go to Member Wong then and see. And I see Member Short, your hand is up.
Yeah, thanks, Chair. I mean, I think part of it, I think even from the start of this whole entire process, I think a lot of us, or at least I'm speaking for myself, is that we're trying to fit what DPH has, and then we're trying to fit what is needed, and then into, all along, I feel like we're trying to fit a circle into a square. And so I think, along the journey, I think, there were a couple comments about, we have a building, but then, instead of looking at the building, how are we going to utilize the building? What can we do to help the population that we have in need for? I think we really need to start focusing on, I think, what the two C's have been talking about all along too. And, and then the mapping system, I think I'm kind of having a clearer picture of how I want to have the mapping. I've been asking for the mapping, but then I think now is, a different perspective of how I want it to look like and how it should come up. And I also like the idea about the site visits. I think a couple of us have mentioned it, but then it never materialized. I think just giving limited of time and the resources that we have, that, some of these things that we cannot pursue. But yeah, it just seemed like we're going a little bit backward, but then I think doing that, I think we can stretch more forward in doing some of the stuff. It just seemed like it was really difficult for us to move, given like DPH just kept bringing up all these things and then try to fit what is needed to what they have or what they intend to kind of roll out. I mean, that's how I felt most of the time.
Chair Lasar, could I, as a member of the committee, could I just?
Please. Yeah, please. And also, I just want to note that we have Member Short also, and a few others to continue to comment. and we're trying to be done by 12. So I just want to note that for everyone. I think we can go over. This is an important conversation, but also member Eisen will have a conflict if we go over 12. So just keeping all that in mind.
Okay, I'll do quick so Sarah or member Short can get in. I just want to spend one thing I think is very important, and this is about the relationship between the IWG working with the Department of Public Health. I've had years of experience with, before you ask for a data plan, you need to have an idea what you're trying to accomplish. We have had contractors who come in, state of California's got that problem now with their implementation of Governor Newsom's plan. I would like to have the IWG weigh in on what kind of experience and orientation and familiarity with the service system in California, if not in San Francisco, any data contractor has. Because data isn't absolute, it starts from a premise. And if we look at the report that was done, the sort of amateur report that was done earlier in this year, a few years ago by Dr. Bland and his team, it started with an assumption that everybody who's in skilled nursing should be there. Everybody who's waiting to go should go there. We need more board and care homes because board and care homes closed. And there was no expansion of recovery-based treatment and services in that recommendation. That was called data 5 years ago, and it could have led us in the wrong direction. What I'm trying to suggest that we're looking at is that there's no ambiguity in the legislation about the importance of our weighing in on, as it says on page 16 of the legislation, fundamental to an effective continuum of care model is providing adequate resources at each stage of treatment. We have experience with that. We don't need to wait for someone else to tell us that their opinion weighs in, but we should be weighing in on that. What are the elements of a continuum of care? There are statewide efforts that have laid it out from every group in the state weighing in on what a continuum of care should look like. We should have access to that data. I could send it to everybody tomorrow. It's a statewide report saying what are the minimum elements of a true continuum of care and what is their interrelationship. But right now we've gotten so narrow that we have, and it says it in the information we have, that this expansion of treatment services has been equated with the beds and facilities report. That's just a small part of treatment services. And what do we get from the recommendations early on? More board and care, more skilled nursing, more inpatient if we can get them, and only one residential treatment program, and that's a very specific model for transitional age youth. So I'm just saying, let's spend some time on talking with one another about what this continuum of care should look like so that we have an idea too of what the elements are that go from 24-hour care to early intervention and prevention, and talk about our plan for working toward that goal. Otherwise, we're going to keep having inpatient hospitalizations, keep having emergency room visits. If our housing model is downtown hotels, we know what the problems are there. We have to start looking at the whole system of care, not just the elements specified in the legislation. Thank you.
Thanks so much, Member Fields. Member Short?
Hi, I just wanted to, thank the group for putting this together. It does look really good, and wanted to just register my extra support for the number 6. I do think that it has felt problematic that we haven't, as members, had more of a hand in setting the agendas and bringing items and doing some of the prep and all of that. So I actually think that's an important one that if we could, bring topics to this. And as Dr. Hammer said, I think part of that is to have more discussion rather than presentation in general. Or maybe it's presentation, but a longer period of guided discussion or something like that. And then finally, the community piece is super important, and we've really not done a good job at that. And that can mean a lot of things, but it could mean just better and further publicizing our meetings and how to attend and how to give public comment, et cetera. It could be, going out to communities like sometimes other commission, I've seen other commissions and such do, where they'll have a special meeting in the Bayview, or, things like that they publicize. And when we're in person, or we can still try and target certain communities though. And then, if it means the site visits, sounds like part of that. And if it means, having some types of different focus groups, whatever you call them, little get-togethers with clients of certain different agencies or service providers at different times, just any ways we can kind of get those folks more engaged and involved, and mostly providing input. I think that's what we really need. We're all in our jobs, connected in different ways to pieces of this, but there's a lot more out there. In that, I think I alluded to this, but particularly how to get more client input or people with lived experience involved would be great. And with that, just want to flag for everybody that we still do have a seat open for that exact category. So, first off, getting someone in that seat, I think would go a long way. Thanks.
Chair Lassar, I have an email from Member Gonzalez who is having some. Yeah, so I'll just read what she said. Sorry about the communication. She said, "I agree with all said, but feel strongest about being strategic as a whole system versus reactive, and am very much worried about the increasing pressures on the behavioral health system. Opioid overdose epidemic, homelessness, new mandated programs, legislation, initiatives, and the inability of us to create capacity due to the hiring retention challenges, especially those experienced by our contract partners."
Thank you, Member Gonzalez. Very much agreed. So I know we have a few minutes left. I think I need to kind of understand this more. I'm not quite understanding everything yet. To understand what the recommendations are. I mean, I think obviously I agree in theory of everything, but I'm not understanding exactly how this gets operationalized. And so, and then of course it leads into my own feelings of, wow, I'm not doing a good job, and I'm failing of where we are. So I have to contend with all of that, frankly, so that I can understand exactly what's being asked for. As I, deeply appreciate you all and your points of view, and want to make sure that I'm clear. So that being said, I think we should. These are recommendations.
Can I respond to your comment?
Oh, sure, of course.
I think that
I also have my hand up and have a comment.
Oh, sure. Okay.
That's not a misreading of what is proposed. This is really, this whole effort has been really directed towards how can the IWG be more effective advising as to the entirety of the system, as opposed to its individual components, and how it can be more functional. It's going to take some discussion about where we want to move forward. I think we're very, very fortunate to have Jen and Ashlyn and the Harder folks. I think when it comes to logistics of how we do this from a meeting standpoint, this is something that I hope that they can provide support and assistance both to the chair and to the IWG as a whole as to how we want to operationalize this. But there is nothing in this report that in any way is intended to be critical of the chair or any other member of of the IWG. I think we're all very supportive of everybody on this committee, on the working group. And I think it certainly is demonstrated by the fact that we've operated by consensus pretty much from day one. And I think that's clearly where I think everybody wants to continue to work together to build and have a better system.
Thank you, Member Lipton. Member Hammer?
Yeah, this was just a comment or question in response, many comments back about the mapping. And we had a presentation. The mapping presentation happened last month at the October meeting. And I think before we keep saying like we need the mapping, we've asked for the mapping, can we put on our agenda for one of our next meetings to revisit that presentation? I don't think we got enough time to discuss it. And if it's not the mapping that we're asking for, then to give feedback to the team that worked on that. But I would just ask that we all as members go back and look at the presentation we got last month, and then revisit it and give feedback if it's not what we asked for.
Thanks so much, Member Hammer. That's exactly why the discussion group is meeting. So given the presentation that was shared last meeting, IWG members expressed that concern. And so that's why we convened this conversation that is happening on December 2nd. And then hopefully with some more clarity on what that need is regarding the mapping from those who attend that meeting, it will be shared back in the December meeting.
Great. Thank you, Ashlyn. So I do want to note that we do have public comment. Should we move on to that section now? I'm just looking, I'm
Chair,
seeing. Yes,
Chair,
please.
hi. Can I just say that, I don't want you to feel like, and I want to piggyback on what Member Lipton has said. It's not a critical of, member, but I think it's just part of the system and it's just the process. And, you did a phenomenal job to actually make people feel included and encourage people to kind of speak up. And so I really appreciate the presence. So I hope that you don't feel that, it's any reflection on anyone or yourself as a chair. So I just really want to point that out.
Thank you, Member Wong. Yeah, thank you. No, I don't mean it in that sense. So thank you so much. I just mean in that, yeah, so I'll come back. I don't want to take too much time with my own processing, but thank you. I appreciate that. Should we go to public comment?
That sounds good to me.
Okay, Ms. Daka, please.
Awesome. So those who wish to provide public comment should call 415-655-0001, access code 2485-747-7444. Then you press pound again, and then dial *3. I see that there is one caller in the queue, so I'm going to unmute you, and then you may begin your comment. You've been unmuted.
Hello. I want to say, talking about mapping, having presentations about mapping is not useful. What you need is a directory. I saw the list that's online. There's a list of services. That's what people need. They need a list of services, how many beds, what kind of people go into them. That's a working piece of material. Having another report is just a waste of time, as is hiring contractors. You guys are the experts, You think somebody from outside is going to make a report that's going to in any way enhance this process? It's not. It's just going to spend a whole lot of money. I mean, I think this whole process, you guys have been working your butts off. You've been doing an amazing job, but we have a director of mental health reform. How come he presented a 2-year-old report that really brought nothing to the table, that had been created by a contractor, which was, you know, why are none of the higher ups kind of, it's like you guys have been siloed. And, you know, you guys know how things are working. Obviously, position shortages are a huge thing. I mean, I would have thought they'd be working on hiring people right away, but I know the city wants to do everything it can, apparently, to avoid hiring permanent employees, which would add stability to the system. And, you know, this stuff is, you guys know that, and they probably know it too. I just see a lot of time wasting and money wasting. And, you know, they need to interface with you more. Otherwise, it just points to the incompetence of leadership at DPH. I'm sorry. It just does. It's so sad. Anyway, that's all I had to say. Good luck, you guys. Take care.
Thank you. I'm going to see if there are any other callers. Currently no other callers, so I think I'm going to close public comment. And then one last, oh, yes.
No, I was just gonna say, we have another public comment, right?
Yeah. And then one last public comment. This is for any other matter outside of the, that's just not on the agenda today. So you would call that number 415-655-0001, access code 2485-747-7444. Press pound and then pound again, and then you dial *3. See if there are any other callers. I think this caller in the queue is from the last agenda item. But I'll check to see if they also have general reflections. Caller, is this a comment on a new item? Thank you. If there are no other callers, I will close public comment.
Sounds like, Ashlyn, it sounds like we may have some comment or some background.
Something's open still. Maybe you can mute it. Thank you. Ms. James?
Yes, so our December meeting is queuing up to be very full. So we are closing within about 3 hours today. Next week our next meeting, we can anticipate a longer meeting. We anticipate there's going to be an update on the Mental Health Service Center, the staffing and wage study. There's going to be a final discussion of this implementation report. And as we just discussed today, like there is still a lot of conversation that we need to have both as an IWG, but also with BHS. These all have to come together and these threads need to be aligned. So we'll be spending most likely a good block of time on that, as well as thinking as time permits, I'm thinking about some community engagement that we might pursue in Q1 and analytics and evaluation. So a lot of stuff. We're probably going to have to pare it down, and we'll be working with the chair on that. Next slide, please. There are, leading up to our December 13th meeting, so remember it's December 13th. We shifted the date because of the holidays, so that'll be our next meeting date. It will be a 4-hour meeting, but there are some things that you can be involved in before. And one of those is the December 2nd. Ashlyn's mentioned that now 2 times, and I know that there's a lot of interest in mapping. On December 2nd from 10 to 11 is going to be a mapping discussion with DPH. Please, if you're interested, and there's a lot of energy in this room, please sign up for that. The appointment's going to be coming soon. December 17th from 3 to 4:30 is the wage and staffing discussion group. That also came up during this meeting. If you are interested in that, please sign up for that. These discussion groups are a way to have really good in-between conversation. We can't emphasize enough, like this is a really good opportunity to get some of your questions answered and to really have a robust conversation. So please look for Ashlyn's post-meeting email. We have a new website. The new website is still kind of figuring out how to operate some of it, but it is there. The meeting minutes will be there within the next couple of weeks. And I believe that's it for housekeeping. Monique, back to you.
Oh,
Could-
was there some other comment?
Yeah, Chair Lucero, I just would,
Yes.
first of all, December 17th is a Saturday.
Yeah, we're not meeting on December 17th. That date is incorrect.
Yeah.
I think
It is
Seems
November.
terrible.
It is
I've
November.
given my life to, I've given my life to the IWG. but
Thank
not my
you. Sorry,
Saturday, so-
November 17th. That is totally my fault. That will be corrected. Thank you for pointing that out.
Member
And I
Fields?
just wanted to say one thing because I don't want to end this meeting on the note on the caller, only because this is a hard work for everybody to do. And as somebody who's perceived sometimes as pushing hard on ourselves, but also with the department and how we find a working agreement, as to suggest that that the Department of Public Health leadership is incompetent, I just think is a erroneous characterization of what's going on here. I think they're overwhelmed like we are. But so I hope we can reach an environment where our mutual respect sometimes leads to disagreement, sometimes leads to frustration. But I'd like to be in more discussions where we're challenging assumptions that might be made inside the department, and that they're comfortable in hearing those challenges, and that we can work toward, coming up with a comprehensive set of recommendations over the next year that makes this legislation not just an act that goes nowhere, but something that actually implements a better system. So I value all of the department reps that have been here, the clarity, the openness that people have had. And this thing's going to work if we're working together with the department, and then all the other advocates out there can channel some of that energy and intelligence and experience to help us decide what this system should look like. So I just wanted to, I didn't want to end on that note with with a frustrated expression of characterizing department reps. Thank you.
Thank you. Member Fields, very sage of you. And I appreciate it. And very well said. Yeah, so thank you, everyone. We're heading into the harvest holiday. So please do take care of yourselves. And also, I know that for a lot of us, we're going to be doubling down, taking care of community. So please do remember to take care of yourselves as well. So many blessings. We'll see you all soon, and appreciations for everyone. Thank you so much. Hopefully we'll see you at the discussion group. I'm not going to even give the date because I'll say it wrong. See you at the discussion group.
The next discussion group is in 2 days. So
In 2 days, on Friday.
On
Thursday.
November 17th.
Thank you. Okay, bye everyone. Be well.